Hello, everyone. I'm Catherine Buford, and I'm the Digital Media Director for Mensah Medical. We're very excited to have you all hear about a topic that we've wanted to share for a while. Today, Dr. Mensa is going to discuss some facts about mental health that a lot of people aren't that familiar with. So we're looking forward to having a very interactive and engaging discussion. So before we get started, I'd like to share a little about Mensah Medical. Mensah Medical provides a drug-free molecular approach to healing using advanced nutrient therapy protocols. This is also referred to as molecular medicine, which Dr. Mensa described in his recent blog post. Each prescription is composed of specific vitamins, minerals, and amino acid compounds. Also, there is a unique design to address individual chemical imbalances at Mensah Medical, and we prescribe nutrients at a therapeutic level, which means the doses are often several times higher than the RDA. So this is not necessarily something that we recommend people try to do on their own. This is truly medicine that is nutrient-based. And together, our doctors have successfully treated several thousand patients with various conditions. So some of these conditions include Alzheimer's, ADD, ADHD, anorexia, autism, bipolar disorder, bulimia, depression, learning disorders, OCD, and schizophrenia. Now I'll share a little about our presenter, Dr. Albert Mensa. He is a family practice physician. He is board certified in integrative pediatrics by the American Association of Integrative Medicine. He has treated greater than 10,000 patients with advanced targeted nutrient therapy. He also serves on the board at Walsh Research Institute and is a clinical instructor for Walsh Research Institute's international doctor training programs around the world. He's also the co-founder of the newly created not-for-profit Mensa Research Institute, and Dr. Mensa has some information for you about that at the end of this webinar. He got his undergraduate degree from Northwestern University and his medical degree from Finch University of Health Sciences at the Chicago Medical School. He completed his residency in family medicine at Swedish Covenant Hospital, and he co-founded Mensah Medical in 2008 with Dr. Judith Bowman. So now I will turn it over to Dr. Mensa.
Hello, everyone, and thank you for tuning in. I'd like to just kind of briefly discuss some very common misperceptions and perceptions. We need to, first of all, understand why it's important for us to actually rethink mental health as a term right now. How can we really sort of review what really is mental versus what is part of the brain? And this is what we're going to kind of address tonight. The benefits of an alternative perspective are extremely important because it's this different perspective that has led to so much success in our treatment protocols currently. We'll also look at questions that attendees have produced, and then we'll talk a bit about Mensah Medical's approach, and then we'll have a Q&A session, question and answer session. Let's talk about the state of mental health. Approximately 1 in 5 individuals in the United States, that's 43.8 million people, or 18.5%, experiences mental illness in a given year. Approximately 1 in 25 adults in the United States, that's 9.8 million, or roughly 4%, experiences a serious mental illness within a given year that substantially interferes with or limits one or more major life activities. Serious mental health illnesses cost America $193.2 billion in lost earnings per year. That's billion with a B. Let's talk about the state of mental health. Now, when we use the term prevalence, prevalence reflects how many or what percentage or numbers actually have a given disorder right now. The prevalence of mental illness by diagnosis is, for example, 1.1% of individuals have schizophrenia. That's 1 in 100, or 2.4 million American adults live with schizophrenia right now in the United States. 2.6%, or 6.1 million, of American adults live with bipolar disorder. 6.9%, or 16 million, of American adults live with major depression. 18.1%, 42 million, of American adults live with anxiety disorders. Now, very briefly, let's kind of talk about these numbers here. These numbers represent the reported cases. We can pretty much determine that there are several million individuals who live with major depression and don't even realize it. Several more million adults or individuals live with anxiety disorders and may not realize that that is not simply the way life is, or that it's not simply situational, or that we're not being reactive to just a whole lot of different life scenarios. There are actual biochemical conditions underlying these, but I believe these numbers to be very, very underreported. Why medications won't cure mental illness? First of all, what most people call mental health is not mental health. The mind and the brain are not the same. What people consider mental health conditions are often really more problems of the brain and not the mind. And they can be very, very complicated. What's the difference between the mind and the brain? You know, we've used these terms so interchangeably that many people really believe, and even in medicine, it's almost understood that, well, the mind is where the brain dwells, or rather, excuse me, the brain is where the mind dwells. And it may be, but the fact is, the mind is far greater than the sum of the parts of the brain. Now, this picture, or these two pictures here, kind of illustrate some very interesting points. Many people have talked about the fact that while they were in a coma or under anesthesia, getting ready for surgery, that they could often tell or hear or had an understanding of who was around them. Now, their brains were actually rather silent, but their minds were actually operating. So there is a distinction to be had. On the right-hand side, we see an individual whose mind is not necessarily functioning very well. She could have major depression, for example, but the brain we see is alert. She's alert, the brain is intact, it is functioning, but her mind is suffering. Okay, so there is a distinction to be had that both of these pictures sort of illustrate here. Let's rethink the role of the brain in biochemistry. First of all, there's several biochemical imbalances that can each individually produce a given symptom. So let's just say the symptom of anxiety. Why, there's a zinc deficiency, copper toxicity, methylation disorders, both under and over methylation, copper toxicities, lead poisoning, mercury challenges, all sorts of biochemical elements involving metals or nutrients, deficiencies or excesses, can actually contribute to produce the symptom of anxiety. So if it is truly a biochemical construct in that these aberrations can produce the symptom of anxiety, we can't really call anxiety a diagnosis. Anxiety is functionally a symptom for many different organic syndromes. We also understand that we need to really sort of review why nerves trying to talk to other nerves don't do such a good job. Why is there a poor nerve-to-nerve communication? And we'll look more at that. When your brain is dysfunctional, your mind has trouble functioning properly, because the brain is kind of the vehicle that the mind uses to move from philosophical or conceptual point A to point B. So there is a relatedness, there is a connection, but we want to understand, even though there's a very strong tie and much overlap, the two are indeed separate. But just like you get into your car to go from point A to point B, so the mind can move only within the vehicle or the car that is known as the brain. There are chemical imbalances that can produce anxiety or depression, and we kind of talked about this a little bit earlier. But some of the elements that we didn't mention. So for example, malabsorption syndromes can lead to anxiety or depression. If your gut is not properly healed or properly working, it can't break down the appropriate dietary components into the microscopic nuclear elements such as nutrients and vitamins. If you can't make or break down those products into their component nutrients, well, then your body can't make enzymes, hormones, or neurotransmitters, and therefore your system doesn't function properly. Excessive dietary fat consumption. Most of us just rather enjoy our pizza. We rather enjoy a lot of foods that are very fatty because they taste so good. And folks, I am certainly not immune to that. I have been there and done that, so I know what I'm preaching here, okay? But I also know there's a cost. And many times these same foods can produce depression, whether it's short-term or long-term. But do you really need to be sleepy, tired, fatigued, and depressed when you've got an important business meeting at the office, or when you're at home trying to deal with your spouse and your family? And I mean deal with in a lovely way. So I don't want to get any letters about that term. But here, diet truly does affect how we think, how we perceive, and how we react. Energy drinks, I think, speak for themselves. We see people so hyped up on this stuff that many of them actually become tachycardic. Their heartbeats race very erratically, and some of them actually end up in emergency rooms. And you know what? At that time, the doctors tend to think these people are having panic attacks until the question of, did you drink or do anything differently, comes up. And then many young people are saying, well, you know, I had 4 or 5 energy drinks, and all of a sudden the doctor goes, got it. So even traditional medicine recognizes that energy drinks can be a big problem. Hypoglycemia. Many of us don't really recognize that highs and lows in glucose or sugar swings can produce reactive or very different and difficult emotional states of cognition and processing. We can get pretty cranky, we can get very grumpy, and we can just sort of snap at people. More often than not, probably at home, but certainly at the workplace, if we just don't maintain appropriate sugar levels. Many individuals are told, you know what, maybe you should have a little protein snack or carry a protein bar with you every 2 to 3 hours to help with that hypoglycemia. This is often what we call reactive hypoglycemia. We spoke about low zinc levels, low vitamin B6 certainly can produce anxiety and depression. Many of you have already heard of pyrrole disorder. But low levels of methyl, these molecules that actually regulate enzymes, hormones, and neurotransmitters, in addition to high levels of methyl, can both produce these same symptoms of anxiety and depression. So if we have so many different potential causes of anxiety or depression, how can we call either one anything other than a symptom? We have to find out what the root causes are. Let's appreciate the difference once again between what is a mental illness and a biochemical cause. How would you expect your doctor, for example, to treat a heart condition like a cardiomyopathy? Your doctor doesn't just say, well, you've got an organic heart syndrome, and therefore we're going to try to treat it and kind of guess what's causing it. No, your doctor is going to order tests. They're going to order scans. They're going to order chemical tests involving blood. They're going to really pinpoint the key areas of problematicity. And then they're going to target those areas and treat them. So there's a big difference between the left-hand side of the picture, where we have an enlarged heart. We have diastolic dysfunction. or where the heart simply isn't working too terribly well, at rest, versus on the right-hand side where we've got a restrictive heart condition, restrictive cardiomyopathy. Now, there we can have very, very tight walls of what we call the ventricles. Those are the chambers of the heart at the bottom of the heart that are responsible for pumping blood throughout the rest of the system. If those walls are rigid and don't stretch very well, you can't get the proper amount of blood filling into the heart so that enough blood can get to the rest of the system. And then there are a variety of different causes and challenges between the two. So it's very important to get the correct diagnosis so that you can get the correct treatment. And that's what we're trying to get across. Mental health, quote unquote, has similar challenges. We have to get the correct diagnosis of what is actually causing those symptoms we call mental health, and then we can target the treatment. There are various types of conditions that are present for even just depression, and each one of those requires a different treatment protocol or approach. Dr. William Walsh of the Walsh Research Institute often talks about the biotypes of depression, and he submitted his research, his work on these biotypes to the American Psychiatric Association, and they have widely accepted these. So there is hope out there. But when we talk about the biotypes, there are 5 major ones that we often refer to. And these represent completely different disorders, each one with a very unique neurotransmitter imbalance as well as symptoms. Treatment for each biotype is different. In some cases, patients can have 2 or more imbalances that need treatment to correct their depressive symptoms. And here, once again, we see overmethylation is roughly 20% of the causes. Roughly 17% is illustrated by copper toxicity. Undermethylation represents 38%. Dysbiosis, diet, and autoimmunity represent 5% of the causes. And toxic overloads, including metals, represents another 5%, just to name a few. Depression is not a diagnosis, folks. Depression is a symptom. It can result from several biochemical imbalances or combinations within a given individual. With different types of conditions, they're going to require different and various approaches. So let's look at some of the causes for schizophrenia, for example, or what we call schizophrenia. And please keep in mind, even traditional medicine recognizes that schizophrenia is really a general term or subject matter involving different, absolutely different imbalances or challenges, each one that needs a slightly different approach. The underlying biochemical issue is what we tend to be more concerned with. These underlying biochemical issues oftentimes produce various symptoms of schizophrenia. Overmethylation is seen in over 42% of individuals with schizophrenia. Undermethylation is seen in 28%. Pyrrole disorder is seen in 20%. Gluten intolerance, 4%. And then others, 6%. Okay? Now, when we speak about these numbers, we're talking about these conditions as primary causes of schizophrenia, not as adjunctive elements that are also present. Other forms of schizophrenia. Now, believe this or not, folks, thyroid deficiency can produce symptoms of schizophrenia. Cerebral allergies can cause symptoms of schizophrenia. Then there's drug-induced schizophrenia. Many of you are aware that this is out there. Many of you are not. So those of you who are even thinking about playing with drugs, please do not do it because you can get schizophrenia from those drugs. Homocystinuria and porphyria, excuse me, we misspelled that one, but porphyria, P-O-R-P-H-Y-R-A-A, another biochemical imbalance. Now, porphyria and pyrrole disorder are not the same. Both do involve ring structures in biochemistry, but they are totally different processes with totally different treatments. Let's talk for a minute about the underlying biochemical issues associated with quote-unquote bipolar disorder. With undermethylation, we tend to see deviations in serotonin and dopamine neurotransmitters. With overmethylation, we tend to see serotonin and dopamine challenges as well. But here's the difference. In undermethylation, the serotonin and dopamine tend to be low. In overmethylation, those neurotransmitters tend to be high. So if you haven't addressed or understood or even tested for over or undermethylation, how do you know, for example, which pharmaceutical drug to give if you're planning on using a pharmaceutical drug as a physician? Because many of those drugs are geared towards increasing levels of serotonin and dopamine. If you're an overmethylator, that's the last thing you want to do. You've got to get to the core cause to begin with. Copper and zinc imbalances tend to be involved in having, well, we tend to see challenges with norepinephrine and dopamine when we have copper-zinc imbalances. Severe oxidative stress can affect what's called the NMDA receptor, or the N-methyl D-aspartate receptor. This has been a really big, important source or focus of research in bipolar disorder and schizophrenia and OCD. The NMDA receptor is huge, and we're seeing that oxidative stress can be a very important cause of affecting change that produces various symptoms, including bipolar disorder. 35% of people with bipolar disorder have pyroluria or pyrrole disorder. Blood hemoglobin disorders that strip the body of vital nutrients are also causing bipolar disorder. Many of you already know that many mental health conditions are not treated effectively. Medical researchers don't truly investigate an individual's biochemistry as part of looking for the source of the problem. Foundational biochemical imbalances are overlooked or often minimized because, unfortunately, in our first days of med school, we're told that biochemical imbalances have very little to do with actual physiologic functioning. When it's understood that the main concern is not always mental health, but biochemical imbalances, well, now we can target the primary causes of various mental conditions central to producing both biochemical correction and mental and emotional healing. Molecular medicine, as we like to call it, addresses the root cause of mental conditions. We have cases here of undermethylation on the left and overmethylation on the right. Now, folks, most of you out there recognize these two people. You either go to work with them or you may get involved with them in some way, shape, or form at some business level. On the left-hand side, we've got Joe Corporate. He's dotted the I's, crossed the T's. He's been a perfectionist all of his life. His tie is impeccably placed. He sits at the computer. He structures life for many people or for his business organization. On the right, we've got the creative fellow. He's the guy who's going to jerry-rig situations to make it work. He's very creative. He's not quite so bound to rules and regulations. He likes to sort of move with the flow. He likes to walk to the beat of his own drum. These individuals are often artists, they're philosophers, they're poets, creative individuals. So in the previous slide, we had two different individuals, and they have different chemical imbalances or different chemical makeups. You've got to understand what the chemical makeups are before you can progress. Now, where must medicine go, having said that? Building upon the knowledge and the wisdom of both Dr. Carl Pfeiffer, MD, PhD, and Dr. William Walsh, PhD, we now recognize the urgent need to explore a patient's biochemistry in addition to non-biological and environmental circumstances. Let's rethink prescription medication for a minute. In certain situations, prescription medications can indeed make mental conditions worse. If you think about the previous slide that we talked about, where we saw that neurotransmitters can have very different roles or different concentrations in undermethylated folks versus overmethylated. If you're going to give a medication to someone to cause an increase in serotonin and dopamine, that may work very, very well if they're undermethylated. But if they're overmethylated, that can cause a problem, including serious risks of suicide. Let's rethink healthcare. Physicians need to ask this question: who are you biochemically? With this information, we can firstly individualize diet and nutrient therapies to achieve improved emotional states. Number 2, we can foster better behavioral stability. Number 3 and number 4, most importantly, we can decrease anxiety and reduce depression. Number 5, we can stave further progression of the disorder or disease by environmental factors. Here we are, folks, and now we can look at the pre-webinar questions.
So this first question comes from Anka. She asked, how do you test for chemical imbalances, and how do you test methyl levels?
Well, chemical imbalances we test for, we can use blood, urine, or hair analyses. When we're testing for methyl, there are actually several different ways to do it, but the most reliable and most consistent ways as a first-line step involve testing histamine levels. Histamine levels and methyl levels are actually diametrically opposed. So what we can do is sort of intercalate what we see from a histamine test by recognizing that as high as histamine may be, methyl is that much lower. Or if histamine is low, that means methyl concentrations must be higher. The two of them literally work against each other.
The next question comes from Stephanie. She shares, I have encountered eye rolls, statements of not peer-reviewed and appropriately scientifically documented, and lack of support by mental health professionals. They believe I'm ignorant and will believe anyone. I stood firm to my beliefs, but I wish I didn't have to advocate so hard just to try a special formula of vitamins to treat my teenage daughter's debilitating depression and anxiety. How do I communicate with my child's therapist and psychiatrist about nutrient therapy in a way that helps them believe that a nutrient therapy program is legit and worthy of trying? I have told them everything I've learned, referred them to your websites and videos. The psychiatrist has spoken directly with Dr. Moen, and still, it's like there is a big elephant in the room anytime I bring up the nutrient therapy we are pursuing.
Well, that's a great question, Stephanie. And I have to say, first of all, you're not alone. I think almost everyone who is listening to this webinar with you has had the same experience. Even when I talk to my colleagues, many of them my friends might even just give me the eye rolls themselves. But here's the situation. First of all, there are now peer-reviewed journal articles. There are now double-blind studies on nutrient therapies. As a matter of fact, even some of the pharmaceutical studies that are in many journals are based upon comparing actual pharmaceutical agents to various nutrients. They just may not recognize them as being nutrients. S-adenosylmethionine, for example, we also call it SAMe, is actually reviewed. It's actually in several journals looking at the role of methylation. Now, they may not refer to SAMe as a nutrient, but we know that it's a natural element. It's not a pharmaceutical drug. So here we can see that that is one prime example, and all you have to do is Google it. There's several articles out there. Stephanie, the hard part is that you're not really going to convince your doctor. This is so cutting edge and so new that it hasn't had a chance yet to get filtered into medical school and be blessed by the medical organizations. So for them, they're not teaching their young doctors about this. In fact, many of the young doctors are actually learning about it on their own. And so there's a lot of misinformation out there. But I want you to hang on, keep working at it, and don't give up. Most doctors that are now actually learning about this and are attending workshops, they're actually given that kind of impetus by their patients. So believe it or not, you are having some effect. Keep up the good work, keep pressing on, keep pushing.
The next question comes from Angela. She asks, is it possible to cause schizophrenia in someone who received antipsychotics when they shouldn't have? And how long does it take for a patient with schizophrenia to recover the biochemical balance in his brain?
Okay, first of all, it is possible for an individual, smaller numbers, but it is possible for an individual to get symptoms of schizophrenia from medications. Now, the key to recovery really depends upon which imbalances an individual has and what other kind of physiologic symptoms that are going on with that person. So we can't give you an exact time frame because remember, schizophrenia is a diagnosis of mental health. The causes of schizophrenia are biochemical in nature. In order to truly answer that question, we have to first test the individual's chemistry to determine what the primary causes or considerations are. Those kind of considerations can be anywhere between 3 months to a year and a half. So we have to be very, very cautious about first targeting the imbalance, and then we can discuss recovery times.
Eli asks, what are the best ways to deal with bipolar disorder without using medication? I have various issues to deal with. There's mania and some issue that has been labeled psychosis and OCD. A medication has until now managed the problem, but I want another equally effective solution to this issue that does not require that I take medication.
Okay. Well, in general, Eli, the bottom line is still first we have to test your chemistry to see what your imbalances are, and only then can we target them. Now, some of that may involve dietary management. Most of it is going to revolve around biochemical imbalances and nutrient therapy, or advanced nutrient therapy, as we call it. So there is a way, but even when we begin that process, Eli, we don't want you getting off your medication. Your medication has to keep you stable while it allows, that's going to be your foundation, while it allows us a chance to sort of work with your chemistry to get things more regulated. And then later on, we can entertain the idea of talking to your psychiatrist about helping you wean off the medication. But please don't get off your medication on your own, especially during the process of change. That would not be beneficial.
All right, well, we want to thank everyone for your brilliant questions, and if any of this information has resonated with you, we would love for you to contact us to see how you or a loved one can become a patient. For more information about Mensah Medical's antioxidant therapy, please contact Mensah Medical at 630-256-8308. You can also email us at terry@mensahmedical.com. Also, Dr. Mensa will be in Burlingame, California with the co-founder of Mensah Medical, Dr. Judith Bowman, May 9th and May 10th. Our main clinic is actually in Warrenville, Illinois, so if you are in the Midwest and Illinois area, you can come visit us at our main clinic. If you're somewhere else in the country, you can visit our website at mensahmedical.com to learn about regional outreach clinics near you. All right, and now we will get to...
If you view a drug as an outside agent that you take into your system, that will have a physiologic or biochemical effect.
Okay. Jasmine asks, can you talk more about treating OCD and the imbalances that are happening in the brain?
OCD used to be one of our most challenging disorders to treat. I would rather see a person with schizophrenia or bipolar disorder walk into the clinic back in the old days than see someone with OCD. They were quite honestly quite simpler to treat. What we're seeing now, though, in the last 4 or 5 years, are many elements that can be utilized to actually speed up the process of healing with regard to OCD. As a matter of fact, this is quite ironic, but just today, my partner, Dr. Bowman, mentioned a patient who had been on one of our protocols, one of our newer protocols with OCD, and don't take this for everyone, but quite literally, 5 days after starting treatment, this patient's symptoms were all gone with OCD. Now, in the old days, and for most of you out there who've been on our older programs, OCD, we would say, would take anywhere from 9 months to a year and a half of treating, and it's usually the undermethylated person that experiences OCD. Now, that process is very lengthy, it's time-tested, but most of the time there's good improvement. But now we have elements that can shift things and move them forward much quicker. You just have to be in the right category. So it's not for everyone, but many people are being able to benefit from a much more rapid progression. You still have to treat the biochemical imbalances, but now other amino acid elements or agents are being added
into the foray, if you will, in order to speed that process. Now, some of you may be thinking, but wait a minute, I've got OCD and I'm over-methylated. Quite earnestly, I suggest you may not have obsessive compulsive disorder. You may have obsessive compulsive personality disorder. When we look at hair analyses, we can actually see the pattern that would indicate that perhaps this person was misdiagnosed. And so it's not under-methylation we're treating, it's actually over-methylation and a view of the personality disorder, not the actual OCD itself.
And Jocelyn asks, is a blood histamine level of 82 over the functional level of 70 to 110 significant?
Okay, now the level that you're mentioning here is just a range that is a laboratory range. Your level, or this level of 82, is significant. It is classic undermethylation. It is something that needs to be treated. It needs to be addressed. It's not going to go away by itself. Now, so if that is you or your loved one, yes, indeed, it may be a cause of some condition that you have, whether it's anxiety or depression. Undermethylators are extremely susceptible to depression. They're also extremely susceptible to a great number of addictive challenges, anything from alcoholism to cigarette smoking to gambling addictions to pornography. A variety of addictions are present with undermethylation. So I don't know exactly what the condition is that you're concerned about, but certainly if you have a condition, you need to get that evaluated and treated.
Janice asks, what are symptoms of copper detox? What is the upper limit of copper toxicity?
I want to answer the second part of that question first. I'm not sure there is an upper limit to copper toxicity, secondary to death, quite honestly. We have seen copper levels in the mid to high 200s actually run in a family of 3 females, a mother and 2 daughters. For those of you who may not know, for us, copper toxicity begins at a level of 110, technically. And it's not like you're worrying about saying, oh, well, you know, I'm a 112, 115. I don't have significant copper toxicity. For every unit of copper elevation greater than 110, it's almost logarithmic in effect. In other words, for example, every 1 unit might represent 10 units of change in pyrrole disorder. So there's a very, very powerful issue going on with copper. Anytime you're simply over 110, you are copper toxic and you need to be treated. Okay, so let me just double check to make sure I got all that part of the question here. So we have the range.
And the symptoms of copper detox.
Symptoms of copper detox. If it's done at an appropriate rate, you should not experience any negative symptoms. You should be experiencing positive ones. My depression is less. I'm less anxious. I may not have heart palpitations as much as I did before rather. But if the copper is coming out too quickly, you might see a worsening of your symptoms. Anxiety may be worse, depression may be worse, impulsivity, brain fog, sleeplessness, irritability. Folks, believe me, I've heard it. And I've heard it from family members as they called me and said, I don't know what you did to my significant other, but the copper was coming out too fast and we had to pull back and lower or decrease the rate at which the copper was being removed. And it can be done. But when you're adjusting for weight and so forth, and this is back in the old days, you learn pretty quickly, and we have. So symptoms of copper toxicity or copper excess coming out too quickly, consider a worsening of the symptoms that you already have: anxiety, depression, fatigue, mood issues, rage, etc., etc.
Okay. Alessandra asks, if you've always had psychiatric symptoms, but later in life ended up experiencing traumas like abuse, an accident, rape, etc., which could lead to PTSD, can nutrient therapy still work? Is PTSD fixable biochemically, or would you still need trauma-specific therapies?
That is a fabulous question, and the answer to all of that is yes. I could just say jokingly, next question. But let's really delve into this a little bit more here. Those are all very serious situations, and I don't mean to make light of them, so forgive me here. But when we're talking about trauma, trauma superimposed on bad chemistry makes a situation far worse than it ever was. Now, what you've done is to overlay an emotionally challenged situation. If you remember at the beginning of the presentation, we talked about environmental factors that could make a condition worse that's outside of biochemistry. What you just mentioned are exactly those types of things. Any kind of emotional trauma now sits on top of biochemical imbalances, and this is very important, please, to all of you listening. It can literally change biochemical markers, not just in you, but those changes in biochemical markers can be passed on to ongoing subsequent generations that have not yet been born. I need to say that again. Whenever there's an emotional trauma, biochemical markers, DNA markers, methyl markers, at the level of DNA in micromolecular mechanisms can be shifted permanently and passed on to subsequent generations. Many of you out there are thinking about some fairly esoteric concepts like emotional memory. Did I do something to my child before it was born? Did what happened to my great-grandfather get passed on to me? And we're not talking about biochemistry. We're actually talking about marks, literally the bookmarking parts of DNA. Those are sort of the boundaries that allow DNA to be read properly, to be read in the proper reading frame, and then produce the right proteins, enzymes, and hormones for natural functional capacities for the average person. Those bookmarks can be changed, sometimes irrevocably, at the level of DNA. But that doesn't mean you're doomed to a life of emotional discontent, disharmony, depression. Those aspects can be circumvented so that you lead a much more happy and beneficial life. And yes, you do still need, quite often, cognitive behavioral therapy or cognitive therapy of some type in conjunction with the biochemical treatments. They go hand in hand. Very, very useful, and together they often have a better outcome than either one alone.
Jill asks, my son was diagnosed with severe pyrrole disorder. He is to be tested in a few months. Can you please explain how zinc and B6 can reduce the levels of pyrroles?
Well, I'm rather curious about that question. You said somebody diagnosed him, but he's not been tested. So I'd like to know how he was tested, or diagnosed, first of all, because quite earnestly, many of the symptoms of pyrrole disorder overlap with the symptoms of zinc deficiency or vitamin B6 deficiency or copper toxicity or under or over methylation. So let's just say that we don't know for sure that he has pyrrole disorder, and it may be assumed. Especially little boys. Oftentimes, little boys who are impulsive or moody or rageful, they can actually have bowel dysfunction, anything from constipation to yeast toxicity that can produce very similar symptoms. Okay? So when we're talking about the treatment of pyrrole disorder, what we're really referencing is acting as a middleman to give the system back what has been taken away by the pyrrole molecules themselves. Now, when you add those elements back into the system, you create the capacity to deal with the stressors that were causing the pyrroles in the first place. So now, as the stressors go down, the pyrroles will also go down, because pyrrole molecules are actually molecules of stress revelation. So they sort of tell you that the system is under stress. They react to stress. Stress can be physical, emotional, physiologic, environmental. It can be, going backwards, environmental like mold, physical like you broke your leg, physiologic like you are a toddler in your terrible 2 years, or a teenager going through puberty, and a variety of other things, disease, colds, flus, cancers, lupus, bowel dysfunction, they can all produce this pyrrole syndrome because they're all stressors on the body. So acting to decrease the stress, acting to replace those elements that help you deal with stress, like the zinc and the B6 and a few other elements, all of those are areas in which we use in order to help decrease the pyrrole levels themselves. So we break the cycle that pyrroles are creating, or participating in, rather.
Donna shares, I've been taking a prescription drug for almost 20 years. Donna, I'm not going to mention this drug to everyone on the call, but I want you to know that Dr. Mensa does see the name of the drug that you're referring to. Is it possible for me to wean off this drug, replace it with nutrients, and eventually be drug-free? My concern is that permanent changes may have taken place over time and that my brain will never be the same. Are you able to help?
Okay, that's a great question, and it's a very common question. Now, the drug that's in question is an SSRI, and I can tell you that, fortunately, this drug is not one of those that causes irrevocable structural changes in the brain. But I want to, first of all, caution the order in which you ask this question. You're not going to stop your medication first and then try to substitute it with biochemical imbalance treatment. First, you've got to have the biochemical assessment, then the treatment, stabilization of your chemistry, and then we have to have manifestation of your symptom improvement. When we have that consistent for at least a good 6 months, then we can start talking, or you can start talking to your primary psychiatrist or physician about tapering off of those medications. Certainly with the medication that you have in question, it is not only possible, it's quite probable. And so I think you're in a good place, but it's going to take time and it's going to take organization. And please do not get off your meds before your nutrient program is in place, or at the first sign of you feeling better, don't jump ship on your pharmaceutical med. You need to keep it in place until the process has taken root.
Jocelyn asks, is sporadic heavy drinking indicative of a particular depression biotype?
That's actually a good question. Actually, all the questions are good questions, but it's a good thinking question. And no, it's not. Not necessarily. The question is, why is the person sporadically drinking heavily? Is this an issue of depression? Is this an issue of dysthymia? Is this an issue of anxiety? Is this situational? There, the question becomes really just a very open-ended question, because many different biochemistries will sort of facilitate the drinking aspect, but they're not necessarily singular in nature. So, for example, overmethylators may drink because they're trying to quiet the ever-going, the ever-thinking nerve cells that just run rampant, and they just can't shut down their brain. Undermethylators may drink because they're depressed, stressed out, or anxious. They're very different reasons for drinking. And so the whole process is one of what's the underlying cause or condition, but there are a variety of reasons why people will drink sporadically.
Kevin asks, why is the combination of pyrrole disorder and overmethylation difficult to treat?
Well, I wouldn't necessarily say that the combination of pyrrole disorder and overmethylation is difficult to treat. I would say that there are a variety of factors that come into play within the given individual. Okay, the number one cause of failure of any treatment in medicine, including biochemical treatment, is compliance. So, yes, there are people who are very compliant and they're still having challenges. The question may be, what's going on with the gut? What's going on with the environment? What's going on with stress entities or stress elements? Are there other elements that we're taking that can actually sort of challenge the biochemical imbalance treatment itself? And I know where you're getting that commentary. Yes, we've seen that as well. And what we're talking about here are relative treatment capacities. Relatively speaking, may be a matter of only a few days, only a few weeks, maybe a few months. it all depends on what we're speaking relative to. But pyrroles in and of themselves are not very difficult to treat. But with mood instability and dysregulation, and then you add to that a mind that is racing and may not necessarily be sedentary and processing very well, it can be a little bit more challenging to simply get across the nature of being consistent, which supplements to take at what point in time, and so forth. But relatively speaking, it's still a very treatable combination.
Michelle asks, my 9-year-old has seen numerous doctors and therapists over the last 5 years. None of the doctors can seem to agree if she has ADHD, anxiety, ODD, etc. Can biochemistry help determine a real diagnosis?
Oh, yes, I love that question. Okay. The beauty of the biochemical approach is that you don't need to have an actual diagnosis always from a traditional perspective in order to effect change. Okay. If you call your car, forgive me, I'm talking to the guys out there, if you call your car Red or you call your car Rufus, it still has 4 wheels and it still goes. Because we look at the underlying causes of the challenges in question, we basically treat the underlying biochemical imbalances. And whether it's called OCD or ODD or whatever have you, those imbalances will still shift and you should still see improvement in the condition. Okay? The label only comes to us because somebody else has provided that label and diagnosis. But we dig underneath the label to find out what the underlying causes are, and then we treat. So for us, whether it's a nomer or a misnomer, it makes no difference. We get to the underlying cause and we treat that underlying cause or causes.
Alyssa asks, taking antipsychotics and mood stabilizers and changing doses has caused a lot of episodic activity for me. I am diagnosed with bipolar. Can you explain why you say we may need these drugs on hand when they can do so much damage?
That's a great question. And what we're talking about are some very, very powerful drugs, especially if you're using atypical antipsychotics. They do begin to restructure the not only coordination of the brain, but the actual receptor site structures of the brain itself. If you remove yourself from those medications after a certain period of time, very quickly, you may have devastating effects, quite devastating. So you need to keep those support mechanisms present to avert possibly even greater consequences by taking yourself off of them immediately. Once we have stabilization of symptoms and we have improvement of symptoms and we've got normalization of chemistry, that's a better time to start talking about taking yourself off of those meds. Now, not you taking yourself off, but your psychiatrist. Now, let's get more to the question. The other piece is, why are you experiencing those horrific side effects? Are they side effects of the medication in general, or are they idiosyncratic side effects? That is, more unique to your particular physiology. These are 2 very different issues. Now, if you're having those kinds of challenges, you should talk to your psychiatrist about switching to a different medication or different medications. Most of the time, it's a trial and error process in traditional medicine to find the right medicine or the right combinations of pharmaceutical agents to help with bipolar disorder. And many of you out there know that. Even for depression or anxiety, it's often the same. The difference is that the atypical antipsychotics are extremely powerful, they're extremely potent, and they do really restructure the brain chemistry. And after about anywhere between 8 and 10 years, those changes are really, really, really hard to undo. Not impossible, but extremely hard to undo. So the reason we say stay on your medications is that this is a cautionary measure. Okay, it's cautionary. You can do as much harm taking yourself off those meds without proper support as you can dealing with the side effects. And feel free to contact us, at another point in time to talk more about what particular side effects you're experiencing and what those other challenges might be.
Okay. So Eli asked a question that I've seen a couple of you ask, which is how long is the webinar going to continue? Because we did mention that it would be an hour long on the flyer, but we also shared at the beginning that we expected us to go longer, perhaps a half hour longer. So we're going to take as many more questions as we can. I know that some of you are raising your hands, but we want to respect the order in which people ask questions. So we're going to go through as many questions that are here in the chat before we wrap up shortly. So we're going to take a few more questions, and I want to remind you all that you do have access to these slides, and also that the conversation isn't going to end tonight. You can always contact Mensa Medical, and we'll tell you how, and you can always follow us on Facebook and post questions there. Also, next month, we're going to be starting a new series where you can get to see Dr. Mensah's face during Facebook Live, where you could share questions in real time with Dr. Mensah and ask him anything that's on your mind on Facebook Live. There'll be a more loose structured Q&A that's not attached to a webinar.
So please don't feel, if we don't get to your questions tonight, there's going to be ample opportunity this year for ongoing conversation and discussion.
Okay. And so in the interest of time, we're going to continue with a few more. Stacy asks, what is the best form of B12 and folic acid for someone that is an over-methylator and has pyroluria?
Now, young lady, you are asking a question that I typically don't like to answer, because then people start to, I know what you guys are doing out there. You're sitting back, taking notes, trying to figure out how to treat yourselves and how to shift things yourselves, and that's not a good thing. But to answer the question specifically, over-methylators tend to do better with cyanocobalamin or hydroxycobalamin. Taking methylcobalamin is like adding gasoline to a fire you're trying to put out. If you are an over-methylator, you've got lots of methyl, but the last thing you need is a methylated version of B12. Okay. Now, for all you researchers and practitioners out there, this is with reference to cognitive health. If somebody has a comorbidity whereby perhaps methyl B12 is necessary, maybe there's a speech and language challenge in an autistic child where methyl B12 injections would be beneficial, that's a different story. But to answer just this particular question, if we're looking at only over-methylation, then the methylated form of B12 is not a very good form to take in. The other part of the question referred to, let's see here.
And folic acid, B12 and folic acid.
Okay, there's been a lot of discussion about folic acid, and folks, I want to tell you, people have talked about, well, this form of folic acid or folate or folinic acid gets into the cell faster and blah, blah, blah. I want to share you the actual rates ultimately make no difference, and let me tell you why. The faster element that gets into the cell still has to go through a process of reconversion to a different form that ultimately takes just as long in process as any of the other forms. So whether it gets into the cell faster or slower, whether it's folinic acid, folate, or methylated folate, or folic acid, it still takes the same period of time ultimately to work. Now, folks, this is not from Dr. Mensa. This comes from Dr. William Walsh, PhD biochemistry, the man who really has pushed all this and had the great success that we've learned about. So please understand, these forms are interconvertible. Once they enter the cell, they all go through different changes. And so realistically, you can use any of those three forms: folate, folinic acid, folic acid. It's been a huge discussion on the web. I know this. I've seen, I've heard what people are talking about, but quite earnestly, there is no functional difference as far as rate is concerned. Now, in autism, that's a different condition, and in a few other conditions, it may be different, but those are condition sensitive. Otherwise, the rates are pretty much the same.
John asks, For someone trying to address anxiety primarily and depression, should legal marijuana be tried? How would the results be different than a Mensah Medical approach?
Okay, that's a loaded question, and uh, quite realistically, the difference here is that legalized marijuana is basically not doing much different than a typical drug would, except it's not a so-called technical pharmaceutical agent, in the sense that it's not getting to the underlying cause of the condition. You may enjoy it, okay, or if you're dealing with the form that doesn't give you that relaxed feeling, that's a different story, but the fact is it doesn't get to the underlying cause. Our whole point is to find the underlying cause, treat it, so that you don't have to deal with those issues like that anymore. When you're taking marijuana or Paxil for that matter, you're still taking an outside agent, and neither one addresses the underlying cause. And that goes against what we're talking about with regard to molecular medicine and getting to the root causes. That's just symptomatic treatment.
Okay, so we're going to take 2 more questions before we wrap up. So Kim asks, my 16-year-old son was recently tested by a partner of Mensah Medical's. He has high pyrroles, histamine is at 83, zinc at 102, and copper 69. He is dealing with severe OCD and anxiety. Is he an undermethylator?
Yes, he is. The histamine of 83 represents undermethylation. So quite true to form, that diagnosis is likely correct as a traditional diagnosis. He is undermethylated, and indeed it is treatable.
Okay. And Donna says, I had a whole blood histamine test with a result of 34. This would indicate low histamine and overmethylation, but I feel better on a SSRI, which would indicate undermethylation. Is it possible that SSRI is making the whole blood histamine test result skewed as it is antihistaminic?
Now that's a great question, and unfortunately, that's a very wide scope there's a wide scope of answers around that. One of the foibles of the histamine test, if it shows up low, is that any type of antihistamine, whether it's singular, whether it's an allergy medication, whether it's immunoglobulin therapy from a year ago, quite literally, can lower histamine and cause sort of an uncertain test result. If somebody has been on pharmaceutical antihistaminics like SSRIs or serotonin and norepinephrine reuptake inhibitors for a very long time, years as a matter of fact, that can push the histamine into either a normal range or a low range. Now, I would tend to suspect, quite honestly, that given your level of histamine, the odds are you're not an undermethylator. Most of these combinations are not going to push your levels from a 70 to a 34, 70 being where the border of undermethylation is. So you might see a shift to perhaps what might be a more normal balanced range, like in the 50s. As a 34, my best guess is that you are likely normal in methylation, okay, and that the antihistaminic effect of those meds have shifted you downward, but your true methylation status is actually normal, in which case you might actually see some benefit from the SSRIs. So that is most likely what's going on. Your histamine test may be skewed a little bit, skewed quite a bit, but I'm willing to bet that you're more likely on the normal side as opposed to the undermethylated side. And please remember, folks, we don't talk about this much. People who have normal methylation oftentimes have several traits that fall into both the undermethylated and the overmethylated categories. Okay? So don't let that throw you off.
Okay, and I'm actually going to take one last question because I saw multiple people ask this question. Paula asks, what disorders do the genetic missing MTHFR cause?
That's a great one. And Some of you out there may be flabbergasted. Most of you who have encountered me or heard me speak or talk or are patients, you know the answer to this one. What it doesn't cause is that it does not have a true significance with regard to mental health disorders. It sounds shocking, and everybody's saying, but wait a minute, all these tests, and it's everywhere, and doctors are using Deplin, and they're treating blah, 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 blah. Listen, folks, MTHFR really revolves around at least two major conditions. One of them is autism, and the other one is multiple sclerosis. There are indeed physiologic challenges and disorders that are arising where the MTHFR test has some greater significance. But as far as mental health is concerned, and we're using that term mental health, the MTHFR is not significant in terms of either diagnosis or treatment. There are plenty of individuals that are documented that are overmethylated and they're homozygous for the C67T MTHFR defect. Okay, so in another way, we can also talk about the effect. Using Deplin in many individuals provides no benefit. For some individuals, they actually do see some benefit, but guess what? They're more likely overmethylated because the MTHFR test doesn't reference the range or the spectrum of undermethylation versus overmethylation. And ineffectually, it focuses on one enzyme out of 15 that in totality determine what your true methylation status is. So caution around MTHFR. There are some very, very important conditions. The more we dig, the deeper we see, the deeper we dig, the more we see that several different disorders, diseases, disease states can be influenced by one's MTHFR status, but typically the mental health disorders are not in those categories.
All right. Well, I want to thank everyone for attending tonight. I want to remind you all that you can make an appointment if these ideas resonate with you and you do feel like Mensah Medical's approach is interesting and worth a try. Please contact Nancy at mensahmedical.com. You can also call our office at 630-256-8308. We would love to hear from you.